presenter, as the organizers himself, reduce on the use of the car. Such as give him maximum attention. Let's give him maximum attention. He's going to have a very important topic. That's Dr. Lina. For the next speakers, the team of video coverage wish that we stand around this area for the best capture of the video.
Those who are interested in getting CPD points, register somewhere to forward your CPDs directly to the medical council. Where should I put? I put it here. And then this one. I can hold it there. Okay. Thank you. So we are going to look at pivotal updates in heart failure. I'll mainly focus on heart failure with reduced ejection fraction, but I'll give a small hint on heart failure with preserved ejection fraction. I have nothing to disclose. So what shall we look at? We're going to look at the epidemiology of heart failure and how this heart failure generally comes about, pathophysiology. Then we shall try to classify and find the etiology. We shall diagnose, then we shall delve into its management. Before we go into the conclusion. So without wasting time, what is heart failure? Heart failure, basically, it is something, it is a clinical, it's clinical. You need to have symptoms and signs of heart failure, which are as a result of structural damage or a change in functionality. Initially, that definition was enough, but of late, we need to have more objective evidence. And what is objective evidence that they are looking at? One, you need at least an elevated natriuretic peptide, and you need evidence of objective cardiogenic, pulmonary, or systemic congestion. So for you to find those objective markers, you really need to do some investigation. Gone are the days whereby you did everything clinically and you started treatment clinically. Over time, we have found out that there are other things that may present like heart failure, but not really heart failure. And quite often you find terms like heart failure with reduced ejection fraction, that's HFrEF. So that kind of nomenclature is best when someone does an echo. When you send a patient do an echo, you're interested in looking at the ejection fraction. Should the ejection fraction come back and it's less than 40, then that is heart failure with reduced ejection fraction. Or if it is above 50, then it's heart failure with preserved ejection fraction. But in between there are other sub-classifications. We have heart failure with improved ejection fraction, and that is if a patient initially had an ejection fraction below 40, you treat them, and then the ejection fraction gets above 40, or if they had an ejection fraction below 40, say around 35, and then you treated, then they get about 10 or more improvement, then that also falls into the heart failure improved ejection fraction. But there is that hazy area between 40 and 49, we call it heart failure with mildly reduced ejection fraction. Initially it was called heart failure with mid-range ejection fraction, but because of treatment implications they prefer to call it heart failure with mildly reduced. The interesting bit that patients in this category almost receive the same medication like in patients with heart failure with reduced ejection fraction, and then this heart failure with preserved ejection fraction is above 50. That kind of subclassification will go into those nitty-gritties, because the medications that work in heart failure with reduced ejection fraction, not all the medicines do work in patients with heart failure with preserved ejection fraction. So the classification helps you in how to deal with your patients. A bit of epidemiology. Apologies for this when I was changing the font. I think that is when to do that. But briefly, what do I want to tell you in terms of a prevalence? Green for black, white, orange like is Hispanic, and then blue, white, and then the rest of the group goes into others. If you're to look, much as this is US data, still the blacks in there correlate really with us. Try to look at the trends in terms of heart failure. It's a cursory way of looking at things that probably if you compare whites and blacks are more at risk of getting into heart failure, probably because of the different comorbidities that they may have. And the trend has been increasing over time, or the prevalence has been increasing over time, and this is happening despite having more improved medication. The theory is it because things are just going bad, people are not doing well despite improved medication? There's also an analogy that probably we are diagnosing those patients, we are getting more diagnostic parameters, so we are capturing more and more and more. Then epidemiology still, and but if you look at survival, if you diagnose a patient with heart failure, what happens to your patient if you don't do the necessary? 1 year survival, this is in blue, okay, you have almost 80%, close to 80%, but if you're not doing a lot, within 5 years you have just a 40% survival rate, and by 10 years if you've not done a lot, almost 80% of your patients will be gone if they're having failure. It's a very good thing to have. If you have heart failure, just ensure that you do the necessary thing. Still, if we are to look at this heart failure is classified into different stages: stage 1, stage 2, stage 3, stage 4. Others who are using the American College of Cardiology, they will use the ABCD, but when you look at those kind of classifications, they almost correlate. What is in this, if your patient is in just stage 1, something that we shall look at in the next slide probably, how do they perform? This case situ is Kanofusky cancer cardiomyopathy. It is a score which looks at the quality of life of a patient in patients who are having heart failure. If they are having stage 1, patient may have just symptoms, but they can do everything. It is not really that limiting. In terms of quality of life, they are scoring 80. But as the stage advances, 4 being the worst stage, you're just there even when you're stressed, you're having symptoms. Probably stage 3, when you do exertion, that is when you're getting most of the limit, you get the limitation. Here, yes, you get symptoms on activity, but it doesn't not necessarily impair your activity that much. So as the stages advance, the quality of life goes on reducing. So how does heart failure come about? The pathophysiology. Depending on the injury, this injury can be ischemia, it can be hypertension, it can be something inflammatory attacking the myocardium. So what happens? There is an increase in the myocardial load. There is activation of the RAS. Every time you want to know heart failure, know the RAS, know the CNS, and know the cytokines. RAS, that is renin, aldosterone, and angiotensin system. Those hormones tend to work in sequence. They help one another. Renin will activate angiotensinogen, will activate aldosterone, angiotensinogen, and then angiotensinogen, aldosterone. Yes, yeah. I'm asking Isma because he's my student here in the city. Yes, and then those two, they have a tendency. The RAS activates the CNS, sympathetic nervous system, and you know what the sympathetic nervous system does? Increased contractility, vasoconstriction. Now imagine the patient vasoconstriction, and then the cytokines themselves eventually damage the heart. Now what happens when there is activation of the sympathetic nervous system or when there is vasoconstriction? That means your heart has to work a lot to pump out blood, and that alone can cause heart failure. And now activation of the sympathetic nervous system, it will also increase on the contractility, and when the heart is failing, you really don't need it to have a markedly increase the rate of contraction. For your info, every time the heart rate goes past 75 in a patient with heart failure, the chances of mortality go on increasing. It is like a failing engine. I usually tell students that heart failure, the heart is like the engine. Every time the engine is faulty and you're moving your car at a very fast rate, the higher the chances that you get a total breakdown. So every time the heart rate is increasing, the more damage, the more cytokines are released. Hence, these cytokines can cause direct toxicity. When there is vasoconstriction, you'll have reduced systemic perfusion. Hence, different deleterious effects. Remodeling is like, I tend to call remodeling like changing the architecture of the myocardium. Either you're getting scarring, more fibers coming in, which distort the relaxation, sometimes the contractility of the heart. But you may eventually also get ischemia, hence energy depletion, and all this. You may eventually go into apoptosis, cell loss, myocardial cell loss, or necrosis anyway. And then eventually the two, that is death. So that is it about pathophysiology of heart failure. I've gone through this, stage 1, stage 2, 3, 4, and the ABCD classification. Maybe just look at the stage 1. What happens? No limitation of physical activity. Ordinary physical activity does not cause heart failure symptoms, but the patient may have something or a big risk factor for heart failure, or they're having hypertensive heart disease, but they're having nothing. Yeah. Stage 2, there is slight limitation of physical activity, but the patient is comfortable at rest. But ordinary physical activities, may result into symptom. Then 3, there is marked limitation, though they are comfortable at rest, but less than ordinary activity causes heart failure symptom. Someone has just done something small, and then they are getting symptoms of heart failure. Then stage 4, definitely, even when they are at rest, they are having symptoms of heart failure. It's just the same. I won't delve into that. Then what is etiology? For students, every time they ask you at etiology, try to categorize. You can start by looking at the pericardium. You can go into the myocardium. You can go into the myocardium, endocardium. You can go up to the valve level. And this is how I go about it. And then probably lastly, systemic causes that may not be directly cardiac. So if we are to look at valvular disorder, common in our setting, things like rheumatic heart disease, but for the elderly, sometimes they're just having degenerative valvular disorders. And then when you go to the myocardium, coronary artery disease, heart attack, hypertension, and then cardiomyopathies from various causes. Diseases, there are those inflammatory disorders, hypereosinophilic syndrome. In our setting, we used to have, nowadays I don't see a lot of EMF, but once in a while I see patients of EMF, potato on stick appearance. I remember the late doctor says, associating EMF and cassava. I don't know where that theory has ended. And then arrhythmias, these conduction abnormalities can have tachyarrhythmia. This can be PDFib, it can be atrial flutter, or you can have just conduction disorders like AV nodal block. But there are other congenital heart diseases, and then overload. Either your patient is having renal failure, you're overloading your patients after an operation, and then there are generally high output states, anemia, sepsis, causes, and then the cardio diseases, as I've said. Okay, so how do we diagnose heart failure? The diagnosis, a very good history. We are told 80% of your diagnosis is got from history, examination, but nowadays with the advance of gadgets, the chat, GPT, people do not take a lot of time into going into the nitty-gritty. But there is a lot you can excavate by just talking to the patient, even before you start touching them. So do a very good assessment, and try to look out for possible comorbidities. Are they having hypertension? Are they having diabetes? Before you go into examination, of course, in examination, it is systemic, right from the hand, move all the way to the face, and then go downwards, looking for symptoms of heart failure. Are they tachycardic? Are they hypotensive? Are they having hypertension? Do they have any other etiology relating to the cause of the heart failure? Are they anemic? Do they have a fever? Are they having a go to the chest, examine. Sometimes it's just a pneumonia exacerbating everything. Though sometimes patient may have heart failure and have a pneumonia. You can't tell sometimes whether it is purely a pneumonia or it's purely heart failure. And I usually tell students, if you know your patient has pre-existing heart failure and they are coming congested chest, don't treat heart failure alone, but it's best treat both as you try to sort out whether there is actually a pneumonia in there. Do an abdominal. Sometimes they're having hepatomegaly, yeah? Just right upper quadrant. However, some algorithms, some classifications that have correlate to increase the specificity of the sensitivity of diagnosing heart failure. There are scores like the Framingham score, where you feed in the different parameters and then you come out. Though on their own, they are still not enough. You may need to go on and do some kind of examination or diagnostic workup. And then what are those gadgets that you use? Chest x-ray is very basic, though even before you start with the chest x-ray, try to find out possible causes, possible etiological causes. Just a simple CBC may pick out anemia, which you can correct at your health center before you even refer to MBALE. You've done a lot of work before you refer to MBALE Regional Referral Hospital. Tease out, are they having causes? You can do a TSH, but that should be targeted still. Then before you move to things like chest x-ray, to look for features of pulmonary congestion, things like cardiomegaly, pleural effusions. Can be bilateral, but even when it's bilateral, it tends to be more on the right side of the heart. If you have capacity to do an echo in the setting, do not hesitate. And when they do for you the echo, you're interested in looking at the ejection fraction. You're interested in looking at are the valves normal? Are they leaky valves? You're also interested in knowing, yes, this myocardium is contracting, but are there regional wall motion abnormalities? Sometimes it could be a case of ischemia, though there are other conductional disorders that may cause regional wall motion abnormalities. But at your level, if you try to pick out the EF, try to assess the valve, try to look at the muscles. Are they hypertrophied? Especially in patients with hypertension, they tend to have hypertrophied muscles over time, the so-called hypertensive heart disease. heart just big, it is not contracting well and has stretched out. In cardiomyopathies, dilated cardiomyopathy, sometimes it can be dilated because of burnt out hypertension, much as the hypertension causes hypertrophy and then reduction in the internal diameter, but over time, eventually the myocardium gives out and starts enlarging. So to try to tease out the possible causes of etiology, and should be strict on such parameters on the echo. You don't need to know it into detail, but you need to know a few parameters. Maybe what I forgot, ECG. ECG is a thing that should be handy. At a health center ideally health center should have an ECG. I recall when I was in Bristol, the person who introduced me into the basics of the ECG, into the nitty-gritty, the nurse was one teaching me at first before I went into the supervisor and the cardiologist teaching me. I realized how these people have demystified tools like an ECG. But here you find an ECG name who doesn't know an ECG. He needs to look for the physician, but there are certain parameters that you need to pick out onto the ECG. Other things like BNP probably are not applicable in our setting. However, if you're having still a 50-50, you're still in doubt, do not hesitate to do a BNP. That is if your patient can afford. But I suggest do those ones, then these advanced ones, probably at MBALE Regional Referral Hospital and then at UHI. They are the people that will be able to do that same algorithm, but I've gone through that. I wouldn't want to go into that. I think I'd prepared this for my postgraduates. That this tumor marker was increase in ejection fraction plus E estimated glomerular filtration rate. Then when we went to the hard outcomes in heart failure like cardiovascular death, the higher the CA125, the more likely that someone had worsening heart failure or cardiovascular death or CVC death per se, including all-cause mortality and sudden death. That was quite compelling. And I think CA125, it's in our setting, though still, in terms of cost, it's quite. Now, what happened? They went on to put those patients on drugs for heart failure. They used the dapagliflozin. In patients who were on dapagliflozin, there was a change in the level of CA125. It reduced. But those patients who were just on a placebo, there was, instead, paradoxically, there was just an increase, implying that when you target heart failure, CA125 also decreases, just pro-BNP decreases. So how do we manage heart failure? Or what are the goals of managing heart failure? The first thing, when your patient is coming to you, I'm breathless, I can't breathe, I choke in the night, every time I lie flat, it's just a few minutes, I'm waking up, asthmatic, most of that, not most, but some of that asthma-like symptom, it is not really asthma. Sometimes patients are being treated as asthma, but they're actually having heart failure. So what, goal number one, improve symptoms and quality of life. I think that is why patients come to us most of the time, but specific in heart failure, try to ensure, yes, I'm improving symptoms, but upon improving symptoms, I'm more prolonging life. There are drugs whereby if you give a patient, the patient will breathe well, feel better. If they're having congestion, they'll get decongested, walk, get back to work. But if they were to die in 1 year, they will still die in 1 year. If they were to die within 6 months because of heart failure, they will still do that. Yeah. So at our level, we don't end at symptoms, but we want to modify Are we going to prolong the quality of life in conjunction with improving survival? Then we bring in drugs that improve longevity. If you have your dad, your mom on heart failure medications, try to see among these drugs, are they just treating symptoms? Mom is breathing better, but do they improve longevity? Then always ensure that you optimize patient education adherence. Now, there is a tendency when patients do start on treatment for heart failure and they are getting better, there is a tendency to get off their medication because they are better. Now, interesting thing, assuming someone's intermittent on treatment for heart failure, they take, they get off. They take, they get off. There are studies that have showed that sometimes they do approximate patients who are not taking drugs at all. And I've showed you the survival curves in patients with heart failure if they are not really on the right treatment. So the other goal is patient education, telling them what will happen, but that your education shouldn't stop at telling them that take drugs, drugs have side effects. Try to explain the side effects so that when they happen, you're able to alter the side effects. Sometimes it's a matter of reducing the doses. Don't make your patients hypotensive because you feel like they need to be on drugs. Try to adjust their medication. And referral is part of management. Never cocoon on patients. If you see things are not working out, you get it? You are at your level down there. Send to Dr. Ismail Tegeki. Pick out one thing which will modify everything. You get it? And even when Ismail is also doing that, you know what? I'm really treating this patient, but I'm finding this patient has AV blocks, advanced AV block, has a complete heart block. There isn't much I can do, but there is Heart Institute. The patient has money. Send. You get it? Recognize referral. And that is what is lacking in most of our settings. And don't refer when colleagues can't do a lot. Try to when a colleague can do something. So we use what we call guideline-directed medical therapy. There are drugs that have been studied to improve morbidity and mortality. They improve symptoms, and they also improve, they add on to longevity. They improve longevity. So what are some of those drugs? I think over the years, these are just some of the study. I'm not going to go into the nitty-gritty, but there are about 4 or 5 common drugs that we use setting. What are those drugs? We use the SCE inhibitors. We have the ANIs, the beta blocker, mineral receptor antagonists, and SGLT2 inhibitors. You realize that most of these drugs are actually acting on the RAS SNS system because that is the axis of deleterious effects in patients with heart failure. If a drug has no effect on the RAS, then chances are you're not doing a lot. Now, this drug, the SGLT2s, were discovered by serendipity. Serendipity means by chance. You're using it for this, but again, you find it's actually working in here. So these SGLT2 inhibitors, they were initially but over time, in patients who are having diabetes and they're on SGLT2, their heart failure symptoms tend to improve, and then they went further to find out what they really are. So with or without diabetes, these drugs have been found to be beneficial in patients with heart failure. The interesting bit, they are the only drugs with compelling evidence in the management of both heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. They are our new kid block. I think lately we are advocating that we have SGLT2 inhibitors in hospitals, and they have promised to bring us a few doses. Though initially they could cost an arm and a leg, now we have Indian brands that are a bit accessible. So, if your patient has heart failure with reduced ejection, goal, ensure you have at least 4. You have here, you have a mineral receptor antagonist drug like spironolactone, like a plurinon. You have a beta blocker, and the beta blocker, I'm not saying propranolol. Not all beta blockers have been studied in heart failure. There are just about 3 beta blockers: carvedilol, metoprolol, and bisoprolol. There are different trials, yeah? There is the CBIS trial, there is the Merit HF trial. I've forgotten the one for carvedilol, but there are about 3. Now, atenolol may worsen symptoms of heart failure. It has that negative inotropic effect. You don't want your patient who is in heart failure to have any negative inotropy. First of all, mostly if they're having heart failure with reduced ejection fraction, they have negative inotropic effect. Propranolol may also fall in that line. Maybe if a patient has thyrotoxicosis, it may be beneficial. Drugs like captopril, lisinopril. Captopril is very cheap. Can start them on that. Though sometimes patients may come back with irritating cough. We have had cases whereby patients with irritating cough have been treated with antihistamines. Antihistamines have failed, and some people have gone on to start anti-TBs. Yet it is a simple switch from an SCE to an ARB. So if they're having, so you either use this or you use an ARB. Now lately there is what we call an ANI, and you're taking renin, neprilysin inhibitors. In the interest of time, I want to go through the mechanism of how these ANIs work, but it's an interesting mechanism which was used. So if your patient, sometimes you use the ARBs and symptoms are worsening. Lately, if the ejection fraction is not improving and is still below 35, you can use an ANI, that is sacubitril and valsartan, but you have to ensure the ARB or the AC inhibitor is off the board. Is that okay? For medical officers in the room? Okay. This is a slide. I'm not going to go into the nitty points. My interest is showing you that these drugs, they are additive. When you bring, say, an SGLT2, a mineral receptor agonist, if your patient has probably 30% chance of survival, but when you add on another drug, then you improve the survival chance to 40. When you add on a third drug, you may improve it to 50, and then the fourth probably to 74% survival. They are additive. When you remove one of them, the chances of survival go on decreasing. That is what they call, those are the so-called guideline-directed medical therapy. They have been studied that said only take them, the patient should take if they can tolerate. Sometimes you want a drug, but the same patient you want to give spironolactone has hyperkalemia. If you can't control the hyperkalemia, best you first leave it. Though there are studies that have showed that it is best if a patient is on hyperkalemia to put on potassium binders to control the hyperkalemia to allow the drug that causes hyperkalemia to work. Dr. Isma, you remind me and I send you that study. Basically, this is what I've been talking. When combined, when all those 4 drugs are combined, the cumulative relative risk reduction increases. And if I'm to go on to the absolute risk reduction, now every time you look at the study, you're looking at a clinical trial. Look at things like absolute risk reduction. They have brought this drug. What is the absolute risk reduction? How much does it reduce the risk before you get excited? There are drugs, yes. You may find the drug has an absolute risk reduction of maybe about 2%. Now, in that 2%, let me show you something. Okay? This is a cumulative effect, assuming maybe you're treating your for 2 years on drugs. Now, this is what I wanted to show you. Every time you do the absolute risk reduction, calculate the number needed to treat. Assuming you have a clinic of 100 patients and you start them on a certain drug, how many of them are likely to benefit? There are is that every third patient, in this case, every third patient will be saved from a mortality within 2 years. And then there is a drug you can give, and it's absolute risk reduction when you convert it to number needed to treat, that you may need 200 patients to save one mortality. Now, all those things have cost implications. So like on a government or to the patient, yeah? So now look at it. A drug probably is one tablet is costing 2,000, but you need to treat 200 patients to save one. And then there is another drug whereby you just need, much as it's costing 5,000, but you need to treat only 3 patients to cause a change. Which drug would you take? Yeah? The one of 5,000. Because you need only a few cases to save, to create an impact. Then the other drug, sometimes it may look relatively cheaper in the tablet, but you need a lot of time. By the time you save one death, you've actually spent more. So this is what happens when you use those guideline-directed medical therapy in combination. That is the number needed over 2 years. Just I'll give you this slide and you go through. Now, the question comes, how do you use these drugs? Remember, there is a polypharmacy. That's one thing you need to talk to your patient. The same patient is the one who is having diabetes. If there are drugs you can combine, DO combos, try to do that to reduce. Initially, we used to have traditional sequencing, where you start one tablet, see whether your patient can tolerate, bring in another. But what we found out, assuming you admitted a patient and discharged, and then on discharge, they're on an ARBC and a beta blocker, then they come back, you get lucky to put spironolactone. If they come back, yeah, they may not come back for you to put the SGLT inhibitor. Now, we realized that there is a lost follow-up. The chances of getting those patients in time is actually minimal. So they come up with what we call rapid sequencing. As a patient has come to you in hospital, you've admitted them, they have stabilized, you're planning to discharge, try as much as possible that by the time you're discharging them, they're at least on all these 4, because you're not going to have a lot of time to get in contact with them. I used to think that it's only a Uganda thing, but even Europeans are struggling with follow-up. Yeah? There's lost follow-up. And remember, when you start treatment, say like in MBALE or at a general hospital, chances that a person deep down there in a health center will change your prescription are minimal. Yet the patient is not on an optimal thing, but they are just continuing. So if you have a chance to put things right when you get the patient, do that. So you would rather start in low doses if a patient can tolerate and there are no complications, and then thereafter go on escalating the doses as you look at the patient response. Our interest is in having all these together. That is the guide-directed medical therapy. This is the trial I was explaining, that this traditional sequencing versus the rapid optimization. In this study, when you go into the nitty-gritty, in the small details there, you'll find that patients who are we used to look at 3 months, patient to be optimized in 3 to 6 months. Vis-a-vis, when a patient is optimized in about, say, 8 weeks, 6 to 8 weeks, they found out a marked reduction in hospitalization and mortality in patients who were on rapid up titration. I think I've tackled a lot, and I've tackled a lot, and all those other things are just looking at survival. And those who are interested in the different drugs, they'll look at them. Maybe one I need to look at, this is one novel treatment, iron, patients with heart failure, iron carboxymaltose, to be beneficial, but sometimes it requires you to look at the ferritin levels if you are interested. So in brief, That is it, but always address barriers to adherence. Sometimes it's just side effects. Don't insist on everything. Try to, yeah, sorry, it was, I'd prepared it for Nile. I forgot just to change that. Otherwise, thank you all for listening. Thank you for listening. Thank you. Thanks for me.
Members, we are going to have an organized handcraft for Doctor. But before we do that, Doctor, I ask you to take a seat and take questions.
Oh, fine.
Then I will invite you back to answer
fine.
them at once.
It is fine. Thank you. Thank you.
Doctor is going to ask a question. So when you ask the question, the hand is direct to you. You ask and they note it down. You will come and answer them at once. Any question for Doctor? Doctor is answering.
Which you would that elaborate in-depth talk on Australia? It was my long case when I was at the undergraduate. In those days, there was they talk about digitalis, deoxy, the cardiac bed, salt vintage.
Yeah.
I don't know, are they still working or they were abandoned by recent drugs?
Okay, maybe let me start with simple things like cardiac bed, putting your patient at 45, sometimes more depending on how they are. At once. Okay, fine. Fine.
Any other question? Yes, there's a question from assistant. You have a question of this one, Dr. Jim to answer. Any other question? Any other question? I need to tell you that we need to shake the look that the doctor's presentation is very precise. And I believe most of us, if not all of us, have either had a heart failure patient or interacted with. I guess for those who have grandmother heart failure, which was under the care of Dr. Peggy. But I need to tell you that the presentation here has changed my mindset a lot, and I believe you too. So, any other questions? Yes, Doctor.
What the BP?
Well, Doctor has noted your question and is going to answer. Can we have more two and we close? Can we have more two? Oh, well, I think, can we have more two? Yes, Doctor.
Is heart failure still congestive?
Is heart failure still congestive? Is the question. Is heart failure still congestive? Yes, sister.
So when they came back, they had a lot of drugs prescribed for them, and one of them was Lasix, which is okay, and as we had explained, that it's not saying we can end up with hypertension. But this particular was Edemacus, had an attack, and we found out the fluids are more outside the extravascular. They totally had almost nothing extravascular, so the pressure was really low. So I'm wondering, can such a child benefit from albumin before we give them the Lasix? Because we kept pumping Lasix every day Lasix, but we were depleting the intravascular fluid, and actually we lost the child. And from the audit, we realized we lost the child due to Lasix because they had no fluid. So what we were giving
doctor has captured that. Thank you. Any other question? Don't get scared. At least 1 to 3. Any other question? If there is no more questions, we shall invite you to come and answer those. I believe they are there. Some ladies are hearing. Go ahead, you have a question. Much as you came late, you have a question. I know. I'm seeing you. You have a question.
I was still wondering where I should ask or not.
Yes.
Like in our Ugandan population, Dr. Asad, in our Ugandan population, Dr. Asad, I think you are aware of that the biggest number of clients go to the traditional healers, and others go to the herbalists. So I don't know how we can help our population to understand that they should come into mainstream medical care. Already, Dr. Lenz is telling us how someone had already burdened taking too many medications and not. So how can we deal with that to ensure that our patients will reduce on the fraction of the patients that go to the herbalists and the traditional healers?
Well, the last chance. Do you have a question? Oh, still thinking about it. Doctor, I think you can come and answer those few.
Okay, thank you. This shows me that you have been attentive. Every time I present and I don't get very many questions, sometimes it's not good. I will start with senior, Dr. Balyejisa, about digoxin. We still use digoxin. The issue is you need to know when to use digoxin. You need to know the contraindications. If a patient comes with heart failure with reduced ejection fraction, that's a patient I would also use, say, the ejection fraction is 30%. I wouldn't hesitate to use digoxin. In such a case, digoxin is going to help me in about two things. One, it has a positive inotropic effect. It improves on the myocardial contractility. Yet I'm interested in improving the EF. And then two, if a patient is having heart failure, but at the same time they're having tachycardia, remember at the beginning of the talk I said every time the engine is failing, not good to rest. The same thing happens to the heart. I wouldn't wish they're having a tachycardia of say 110, yet my target is 60 to 70. Sometimes you're using a beta blocker, but the beta blocker, that beta blocker is actually also not working a lot. In such a patient, I would add on digoxin, because digoxin works at the AV node and it reduces on the chronotropic effect. So when you reduce on the chronotropic effect, you are likely also to reduce on the heart rate. The other part where I would use, the third part where I would use digoxin, if a patient comes in with heart failure and atrial fibrillation. Other than those cases, it's not good to use digoxin anyhow. Then cardiac bed, I think that is the first thing. When a patient has heart failure, ensure, and even in your clinics, always ensure that you have cardiac beds for, at least even if they are just 2 or 3, for a few of your heart failure patients. So it is true, cardiac bed still exists. We still use it, more so in those patients who are congested. The berry juice, I haven't come across the specific berry juice, and I wouldn't wish to overcommit on it unless someone has something. Then heart failure, pre-existing hypertension. These are some of the tricky cases, the advanced cases of heart failure. And these are some of the cases whereby I wouldn't wish you to tamper a lot. But if there is something correctable at your level, say anemia, proceed and correct that anemia, proceed and treat the coexisting infection. Sometimes this hypertension is because of the sepsis. Treat it, oxygenate, find space, refer. Is that okay? Because you're going to input in your Lasix and you cause more marked hypotension. Sometimes these are patients who require inotropic support, IV inotropy, where you're putting on drugs like dobutamine, raise the BP a bit to acceptable level, then start decongesting. Very tricky cases even in advanced centers when a patient comes in with marked hypotension. That's it. What happens when a patient, say, has borderline pressures, maybe systolic blood pressure 100, but is relatively stable, work around those dosages, still find a way which drug do you tolerate to be in lower doses. Can your patient tolerate to be on low doses of Lasix? Do that. Which drugs should you maintain? Yeah? Try to reduce drugs that don't improve on survival, but instead reduce on the BP. Try to leave more of the drugs that improve survival. Still, you may do that and still the patient is getting hypotension. Go on and reduce the doses. Guideline-directed medical therapy, it doesn't mean that because dapagliflozin or captopril is to be given that you should just give it anyhow. The patient should be able to tolerate it. That is the condition. They can't tolerate, first put it aside. And then when they are able to tolerate, try improve. Then congestive, we still is heart failure is not always congestive. Sometimes patients, the heart failure symptoms, they just have fatigability. They only have fatigability, but not really. They are having symptoms of congestion. So it is not always congestive. And then, all the patients giving lasers, depleting vascular volume more. In such a case, if the patient has maybe hypoalbuminemia, because when you have hypoalbuminemia, that lasix, those diuretics, that lasix works when the albumin is albumin for it to work. If you don't have that, it may not work well. Then there's also what is called diuretic resistance. Sometimes you're giving your lasix, but there is a tendency of patients, when you give your lasix, it will work at the low. But at the end of it, the whatever, the nephrons are also adjusting for your lasix. There is a tendency to increase the aldosterone receptors. You get it? So making diuresis so hard. Sometimes it is a case of doing a dual nephron block to improve on the diuresis. We have various ways as how we try to manipulate. Sometimes I'm giving lasix with blocking the distal completed tubule with drugs like tolazone, hydrochlorothiazide. Sometimes I'm also adding tolvaptan, yeah, which is an aquaretic pill. You're maintaining your sodium, but trying to lose as much fluid as possible. So in this case, it could have been a case of diuretic resistance or a case of pre-existing hypoalbuminemia, whereby you had to improve the albumin. And then understand it. Yes, Dr. Saka, there is a tendency of patients. This doesn't happen only in our heart, but most patients, we still have that tendency of believing more in herbalists. But before we say that patients are going to herbalists, we need to understand also how we work. Get it? Those people, if you listen to them, even if you find those herbalists on the street, in MBALE here, every time I'm passing, there is a herbalist in the corner there. But you find a line of people listening in the sun. One, they take time. Patients need time. Let a patient not come into your clinic before you assess, before you establish rapport. You want to give medication. I mean, how will a patient trust you? You get it? Treat patients holistically. Part 2, try to educate them on the pros of herbs. I recall when I was in the view that some herbs actually cause that opinion and all the side effects in there. You just have to talk to your patient yes, it's okay. Be open that even our drugs that we use are bought from herbs. Yeah? We also use herbs, but we purify them and also tell them about the dangers about the non-purified herbs. But it's a very big problem. Even the elites, they go there, and when they get problems, that is when they rush back. But it's all to do with the patient education. I get to end there. Thank you.
Thank you, Doctor. That was a presentation from Dr. Muinda Assad. Thank you so much. We are going to have a very organized day handicap to appreciate the presentation of Doctor. And on that note, I request the Sister Amina to come and give us an Asante Sana handicap. An organized one. Sister Amina, come in front. Come and lead us in an organized Asante Sana handicap. Amina Nambozo. Sister Nambozo, if you are not able, appoint someone for us. Okay. Sister Amina, your namesake has volunteered to take over. We are going to have an Asante Sana organized hand club.
Okay, thank you, Doctor, for those wise answers that you've echoed. I would love everyone to put your hands together. And then we are going to say, let me first give you a directive. We are going to say, Asante Sana. Ongeza tena. Tena ya mwisho. That's how we are going to do it. Thank you. Doctor, we're really going to appreciate it, and people is ready to receive our thanks. Asante Sana. Karibu tena. Ongeza ya mwisho. Thank you.
Thank you, Sister Amina. That's so nice. That was for Dr. Muinda Assad. Next on our program, we are going to know IMAU in various categories: constitution, leadership, you see, and membership, projects. And I believe most of us have paid our subscriptions within the room. I believe that. Dr. Saka will tell us all that. And those who have not paid, who are not here, will also be told how much they are supposed to pay and so forth. So, Dr. Saka, please, you are welcome.
Assalamu alaikum wa rahmatullahi wa barakatuh. Assalamu alaikum wa rahmatullahi wa barakatuh. Yes, after appreciating our doctor, Dr. Sati Muinda, I request that you can greet your neighbor. You say salam to your neighbor. Yes, and then that is the beginning of my presentation. That is the Islamic brotherhood that we are trying to build amongst ourselves. We get to know each other. Who are we? To have two FRCP fellows. That is the MRCP. Hey, we have one. we have Professor FRCP and then Dr. Assad, MRCP. Those are high qualification awarded by the Royal College of Physicians in the UK. Who are we to have the only Mr.? If you're a Mr., how many Misters do we have here? I think, Doctor, you can say some people have just come, they may not know that you have a Mr. Whereas Dr. Rulenzi was saying that he's married to a man, but there's someone who is married to the only Mr., probably in Ergon region. So, dear Elder, Dr. Badia Jusa, we are glad to be with you, and the rest of you in your different capacities. Like I was introduced earlier by the names of Dr. Saka Mustafa, working with the Department of Physiology, Makerere University, IUIU, and Clark University, and also a member of Islamic Medical Association of Uganda, serving with Kampala branch as the Executive Secretary, and also working with the National Executive to ensure the revitalization of our great institution. In the Islamic world, or in the Islam of Uganda, you realize that we have very few institutions that have stood the test of time. One of them is the Uganda Muslim Supreme Council, and we are proud also that we have one, which is the Islamic Medical Association of Uganda, which was begun in 1988.
So as the organization is growing, we want also the younger colleagues plus the elders to work together for the betterment of our Muslim community. So I am going to present to you, or I am bringing to you, the great organization which we are going to learn together through our website. So, any institution to stand, to be firm, to live longer, it must have guiding principles. And Islamic Medical Association of Uganda has its constitution, which we can see here, but the most important issue we are going to look at, what are the objectives of these great institutions? I am fully aware we have our young colleagues probably that have not heard of our great institutions, but this is the chance we use when we meet you to ensure that at least we share. And also the elders are here, they will be coming in here and there in case I miss something or two. So what are the objectives of the organization?
Yeah, I think that's where I may come in.
Another microphone.
Yes, to understand IMAU. Continue.
Yes.
In the past, as Dr. Ovalodis was telling you, 1988, these ladies were not there. We're using typewriters. And some of us are born before computers were even anywhere. But now, this generation, now is the generation of computers. All of you have them on your phone. So we have also moved digital. If you want to know about IMAU, you just go to your phone, go to our site, which is what?
www.imauganda. Yes, www.imauganda.org.
Yeah, just go there. Whatever you want to ask, just ask, and then you get the answer. So let's just highlight on a few of the objectives, the most important ones, I think, for this particular scenario. So let's start with the first one. The first one. The first one is, can you read for them?
Yes, the first one is saying to be an agent, guide, vehicle, and driver to increase the provision of the highest possible quality, selfless health service for Allah and our country.
So that is the objective number one, the most important. A vehicle. Some of you have heard of the NRA bus. It got where? Probably in our But for us, we are going to Allah. And our bus is taking us to where?
To Allah.
Yeah, this is our vehicle that we're using. Because Allah gave us a privilege to learn medical sciences. So this is the vehicle that Allah again has given us to move forward. Go number 2.
Yes, B is saying to contribute positively to the preservation of religion, preservation of life, preservation of wisdom, preservation of inheritance and heritage, and preservation of wealth in the health sector in accordance with the purposes of Sharia.
Yes, these are purposes of Sharia. Makassid of Sharia, I think you have our person to guide the organization on that. But if you don't have, one of the things that we encourage, every branch must have a branch spiritual counselor, branch check. So you have to identify one to help you to deal with the spiritual issues, Islamic issues. One or more. A number of them to help you with that. But one of them here, for example, that is preservation of our heritage and inheritance. That's part of our Islamic culture, Islamic guidance in the Sharia part of the purposes of Sharia. How to preserve, we started it in 1988, how to make sure we preserve it for many years to come. Then go to, let's jump there. The number C, perhaps is the last one we shall do on this side.
C, to unite all Muslim medical professionals including medical and dental practitioners, nurses and midwives, pharmacists, allied health professionals, and other auxiliary health professionals to each other, and to encourage them to know each other and to work together in the promotion of Islamic principles and practices in healthcare.
That's what we are doing now. Just like they're saying you have MRC, it was FRCPs, manya behavior, I don't know. I just want to know who is who. Yeah. I mean, specialists in this or the other one. So that's one of the objectives of this organization. And I'm glad we had an MRCP, and he's going to become FRCP, hopefully, God giving him life. Sure. And I wanted him to become a professor also. In due course. He's teaching well. Another way.
Allahu Akbar. Allah ilaha illallah. Allahu Akbar. Allahu Akbar walillahil hamd.
So I have a potential professor of internal medicine, inshallah. And I was interested, I was very happy with his teaching. Although when I was examining for MRCP, the one which I was mentioned, when I got to examine, people I no longer see these heart failure things you're describing. The people they bring for us, buying us car, stenosis car. So treatment of heart failure, I think, is but now both medical and surgical. Yeah, so I think that one will come another day. The teacher is still with us, we shall. But I mean, I'm glad we need to know each other and help each other to develop. But number the other one, N?
H. It is.
Let's look at H, yeah.